Okay, so let me share my screen. There we go. Let me make myself smaller. There we go. Right, so hopefully that's working for you all. So we've got about 50 minutes talk, and then if you have time for questions at the end, it's probably the easiest. Suzanne's going to keep an eye on the chat for me. So I'm Hannah. I'm one of the Agile and Foremost Health officers. My day job is as a research physio working in Camden for Central and Northwest London. So I'm currently at the end of doing my PhD. So today's a little bit of a whistle-stop tour of what I've been doing my PhD on, and what I'm really passionate about is looking at vestibular dysfunction in older adults and its association with balance and falls risk. So as I said, it's going to be a very whistle-stop tour because it's a topic that I could talk about forever, but I've only got 15 minutes, so I've got to keep it short. But if it is something that you're interested in, do drop us a line and we can think about whether we do another webinar on any of the topics we talk about later in the year or next year now. So yeah, just let us know. So I'm going to talk briefly over the anatomy, then mainly focus on its role in balance and falls prevention and why I think we should all be assessing it, and then talking through how we can actually assess that. And so I've put on here for community physios, because this is my background. So my day job is going out into people's houses and seeing people there and doing, obviously with very limited equipment, haven't got access to sort of specialist ENT equipment, but stuff that we can do sort of in any situation without that bit of equipment that any physio I think should be able to do. So when I'm talking about the vestibular system, I'm talking primarily about the peripheral vestibular system as opposed to the central vestibular system. And that's because that's where the vast majority of problems occur, particularly for the population that I see, older adults. It's far more likely that it's going to be a peripheral problem than a central problem. Obviously, we do need to be aware of any sort of other red flags, as you would for anybody, that might indicate there's something central going on. So when we're talking about the peripheral vestibular system, I'm talking about the part that's located in your inner ear. And during normal balance, so in a healthy adult, when you're walking on a firm surface even, it contributes to about 1/4 of your postural control, with your vision and somatosensory making up the rest of that. But if we think about, if we suddenly make it harder for your somatosensory system to feed back, so we're walking on a cobbled surface, your vestibular system's got to kick in even more. So it goes up to about 60%. If suddenly the street lights go out and it's now dark on this cobbled surface, it's going to rise even more. So you can see that it's got two main, what's the word I'm after? Two main functions. It's to provide constant feedback as to your head's movement and position, and it also stabilizes your gaze during movement. So your VOR, that's your vestibular ocular reflex. And this is one of the things that can get really complicated, and you read the textbooks and you go, oh, I have no idea what it's saying. But the way that I've always found easiest to think about it is if I'm going for a run, my head's moving up and down, so my eyes are moving up and down, but the horizon stays still. And that's because my VOR is kicking in. So every time my head moves up, my eyes move down in the same speed and same amount in order to stabilize my gaze. So you can imagine if there's a problem with that and the horizon's bobbing up and down as you're moving, you can see that that'll make you feel pretty unwell, probably like dizzy and disorientated. So this is what it looks like, your peripheral vestibular system. So the main things to think about are these semicircular canals. So there's 3 of them at 90 degrees to each other, covering all ranges of movement, and they're filled with fluid. And as you move your head, this fluid is sort of moving around and pushes the ampulla at the end of them, which is just a gel-filled bud. And the amount that moves, both the speed and the direction, is therefore feeding back as to how fast and quickly and what direction your head's moving in. And some vestibular diseases, so something like BPPV, where you get crystals in those fluids, are therefore hitting against the ampulla when you're not necessarily moving, or at a greater force than if you're moving, than you're actually moving, giving false signals back to the brain. So the bit that I'm really interested in is how the aging affects your vestibular system, and it's something that's not really been looked at in the research. So we know that, as with any any system, any bodily system with chronological ages, it deteriorates with age. So you can see some of the parts that deteriorate there. And we also know that vestibular disease prevalence massively increases with age. So those studies quoted at the bottom, the AGILE study was a huge study in America. I think there's like 10,000 people that they surveyed, and they found that about 35% of those aged over 40 had a vestibular disease, but that rose to 85% of those aged over 85 years old. And BPPV, one of the most common vestibular problems, is 7 times more common in those aged over 65 than under 65. But what we don't know at the moment, or there's limited research, is how much this chronological aging impacts on falls risk in older adults. So there's been a couple of studies that show that dizziness is quite a strong predictor of falls, and particularly recurrent falls. And dizziness, I picked up there, is that's one of the main symptoms of a vestibular problem. So the OR, for those of you that are not that familiar with the research side, is your odds ratio. Sorry, excuse me. So this is how many times more likely you are to fall compared to not having dizziness. So these studies showed that you're between 2.3 times to 9.3 times more likely to fall, depending on the severity of dizziness and whether you're looking at sort of just all falls or recurrence and multiple falls over a time period. We also know that if you have a vestibular disease, so if you're diagnosed with a vestibular disease, you have a markedly increased falls risk. So you're 6.5 times more likely to fall. There were interesting studies done where they surveyed anybody who came into A&E with a fall that wasn't sort of from a true medical cause. So it wasn't somebody who'd had a stroke or a cardiac event. It was what we would have called mechanical fall. And they asked them to fill in the vertigo symptoms scale. So this is subjective reporting of vestibular symptoms. And it showed that 80% of them had vestibular symptoms, but none of them had a diagnosis. What we don't know from this study is they didn't have a control group. So we don't know how prevalent it was in the non-falling group. I just have a sip of water. So the work by Matthew Liston then built on this. So he had a group of fallers that were attending a falls clinic at Guy's and Tommy's in London, and compared this to healthy adults and put them through a sort of a real battery of both the subjective reporting of symptoms and objective testing, and found that those that were attending falls clinic were significantly more likely to have a vestibular problem. But interestingly, none of them had a vestibular diagnosis. That was one of the exclusion criteria from the study. So these people were testing as having abnormal vestibular dysfunction, but without having a known vestibular disease. So one of the reasons for this is that when we think about vestibular symptoms, it's traditionally taught that you have to have dizziness and particularly vertigo to have a vestibular dysfunction. And I've put on sort of the agreed definitions of those words. And as you can see, they're not the easiest to understand, particularly the dizziness one. And I'm saying this as somebody who's studied dizziness for the last 4 years. I'm still not entirely sure I understand exactly what it means. The vertigo is a bit clearer. It's this sensation of self-motion, either of yourself or the environment, when there's no motion happening. And it's normally a rotating movement. We often think there might be nystagmus as well. So these are sort of the classic signs of a vestibular problem. However, one of my studies and other research has shown that actually older adults don't necessarily report vertigo or dizziness. They generally report things like they're just feeling a bit unsteady. They might have fallen. They might be avoiding situations where their vestibular system's challenged. So they might have stopped going out at night. They're not going to say this is because my vestibular system's challenged. So it comes down to our questioning and our history taking from that. There might also be an unconscious adaptation of movement. So they might feel dizzy when they look at the top shelf to get something out the kitchen cupboard. So they take a step back instead to be able to see up. But obviously that could also be for a variety of reasons. So that could be because actually I've got really bad cervical spine away as well. So it's where it really comes down to our history taking and being really clear that actually you don't necessarily have to have vertigo or dizziness in order to have a vestibular problem, particularly the older adults. So thinking about what we can do from an assessment point of view, and I said this is where a lot of vestibular stuff, it can get really, really complex, and there's all sorts of horrible tests that they can do if you were to go to an ENT clinic. But what I think, and what the research is showing, is that actually we should be doing this for anybody that's falling, anybody that's reporting a balance problem. There's some really simple things that we can do. I do this all the time for my community falls patients where I have no equipment. I'm in their own help by myself. So I have to be sort of quite risk averse at times to what I'm doing. But I think, first of all, we can ask them whether they're having dizziness or vertigo. Being clear as well that if they say yes to one of those, being clear that we've got a shared understanding of what they mean, particularly, well, actually both of them. So one of my other studies was looking at older adults' understanding of the words dizziness and vertigo, and there was a huge range of answers from that. So somebody might tell you they feel dizzy, which to them is that they're feeling like the world's rotating, and you go, oh, okay, that feels like they're going to faint. Obviously two different things. So unless we have these conversations, we're not sure what somebody's saying. So we need to be really clear from that. Going back to the previous slide where I talked about older adults not necessarily reporting dizziness or vertigo, we could ask them to complete a validated outcome measure, which assesses for a wider range of vestibular symptoms. So the two that are most commonly used are the dizziness handicap inventory or the vertigo symptom scales. The name of these is a bit misleading because it does actually ask about other symptoms rather than just dizziness or vertigo, but are really easy to sort of self-fill in. Takes 5 minutes to do. Obviously, if somebody is reporting vertigo or dizziness, we want to know about ags and easing, how long it lasts for, all of the stuff we would do for anything really. And in terms of specific vestibular tests, what I would do is observe for nystagmus. So I'm just looking, you can do that. Looking for smooth pursuit, so seeing how well they can follow your finger. So you want to do horizontally and vertigo right to sort of their end of range of ocular range of movement. Is it nice and smooth, or is it sort of jerking all over the place? You'd want to look at saccades as well. So this is how quickly somebody can sort of flick between two points, and whether they can do it sort of just in one jump, or there's a jump in the middle, or it's taking multiple jumps from that. You might want to do a head thrust test. To be honest, I don't necessarily do this with my population because there's quite a few contraindications in terms of the frail population that I see. What I would do is sort of a modified VOR cancellation test where I get somebody to fixate. So I'm going to ask them to fixate on my thumb. Can they shake their head? Can they keep looking at my thumb while shaking my head and observing them? Are they able to keep their eyes on there? Is it provoking their symptoms from that? And you may also want to do a Dix-Hallpike as well to see whether there's BPPV, and move on to an EPLES if there is. And so I have put some videos on there, so I think we can share these slides afterwards that just talk you through some of these tests. Sorry, something in my throat tonight. And then just finally thinking about some of the barriers to this, and I realised as I submitted this, I sort of missed out the main one, is that actually this can be quite a lot. If I'm going to do this on top of, I've had to go and do my subjective history, I've done a multifactorial falls risk assessment, I'm looking at the environment, all the other stuff that we do as community physios, it takes time and could be quite a lot. If somebody has got a vestibular diagnosis and they're often put on vestibular sedative medicine, which should be short term, but they're used for, sorry, often used incorrectly for a long time, and you're going to get abnormal responses to that. So obviously anxiety, fear, they're not the most pleasant. They're not the most pleasant to test, and if somebody has experienced dizziness, it's not very nice, and they probably don't want to do them. As I talked about, there may also be sort of other adaptations. So there might be other MSK problems, lots of other things that you need to think about from that as well. So it can be quite tricky, but I think there are some really simple things that we can do with all of our falls patients, and we should be, because in a healthy adult, we know it's contributing 25% of your postural control. And we know that that deteriorates with age, but we aren't really assessing at the moment. Yeah, so my take-home message are, I think we should be thinking about vestibular for all of these patients. So I do what I've talked about as standard for anybody that I see that has either fallen or is at risk of falls. Not everybody with a vestibular problem feels dizzy, and a vestibular dysfunction for whatever reason is linked to an increased risk of falls. So I've put my email on there. I can put it in the chat as well, but if you want to get in contact, please do. But I'll stop sharing now, and if anyone's got any questions, we've got a bit of time for questions.
Has anyone got any questions for Hannah? There's nothing in the chat at the minute. Everyone's staying quiet. Please feel free to unmute yourself and just shout out, or
hi Hannah.
Hey.
Hi, that was great, thank you. I've just got, I'm sorry I missed the last bit, my just died. But have you got any advice for kind of testing and practicalities when you're assessing older adults with severe cognitive impairment? Is there any kind of tips and tricks that you found when they might not understand the process of how you're testing and why you're testing? If you've got any advice on that, that'd be great.
Yeah, I mean, I think it is really tricky, and basically comes down to observation and trying to sort of find clever ways of doing things if they're not following you exact instructions. So I'm just thinking of things like saccades rather than fingers. People often struggle with that. It's can you look at your wife over there? Can you look at that picture? So you might not be getting exactly the true range of movement, but it's easier instructions for people to understand, the sort of prioritizing what you're looking for. To be honest, a lot of, if somebody's really cognitively impaired, I tend to just sort of add a vestibular rehab type exercise into the program anyway, on the basis that there probably is a bit of a deficit. It's not going to do them any harm by doing these exercises. And if it has an added benefit, then yes, from that.
Brilliant, thank you.
Anna, somebody's asked, Sky has asked, can you recommend a good vestibular rehab course?
So I did one at Queen Square, but it was quite a long time ago now, to be honest. But I imagine they still are.
Yeah, I think they are still doing it. I did mine a long time ago as well, Hannah, but I think they still run. It's like a 4-day course, isn't it?
Yeah, that was the one that I did, but yeah, 10 years ago or so. But I imagine Queen Square in London would still be running that.
Thank you. Okay, next question. If a patient was testing positive for vestibular problems, what would you do next? Refer back to GP or ENT?
So it depends on the severity of the problem. That I tend to sort of just add vestibular rehab exercises into my falls prevention program. If somebody was presenting us who was really severe, so that wasn't diagnosed, I would ask for referral on to ENT. But to be honest, I've rarely done that. Because most of the people I see is sort of a low level of function. I would refer in my discharge letter, I would mention it back to the GP that it had been a problem. I haven't in the older adult population seen a huge benefit for them being referred on to ENT, because they tend to just put them through lots of horrible testing that don't really tell us any more than we already knew, and the outcome is the same, that they need vestibular rehab. So we could just sort of cut out the middleman. I don't briefly talk about some of the testing. So I have been through it as a patient, and they do things like they stick hot and cold water in your ears, and they deliberately like spin you around on chairs, and stuff. It makes you feel awful for them to tell me I had a vestibular problem, which I knew anyway. So I think leave it up to the GP, but I don't see a huge benefit for most of our frail population that I see.
Okay, that's great. Thanks. Leslie said, thanks, really interesting. What next if you suspect vestibular impairment? And it'd be great to have a session on treatment pathways. Is the main treatment pharmaceutical? So I think you've kind of, there's another learning club, another learning event for us going forward. And would you suggest all therapists start including this in falls assessments even without proper training, just as a start point?
Yeah, and I think as what I've sort of quite passionate about is that something we should be able to do. Not everybody's going to be an expert in vestibular rehab, but the basics that any physio can do in whatever setting from that, those things that I've talked about, just asking somebody to move their eyes, we can all do that. We can all add basic stuff into our treatment without being specialized from that. So yeah.
Okay, Sarah, can you take over the questions while I deal with the other issue?
Yeah, I was just saying, Hannah, there's a question because I've been dealing with other things as well. How do you score, grade and quantify? Have you answered that one?
No, I haven't. So I would, so you could use things like from the dizziness handicap inventory, depending on their score from that. There are sort of set cut-off points for mild, moderate, severe symptoms from that, which is what I would normally do.
And a few people in the chat have said that the ACFIR group, which is the chartered physios in vestibular rehab, have some really good resources, and they have lots on their website if people are particularly interested with those. Somebody's asked, do you do a Dix Hall Pike with most of your patients, and which patient groups would you not?
So I would like to do it on more patients, but having seen them in the community, often the environment limits us. I think if people were coming to me in the clinic, I would probably do it on much more patients, but often just I don't know, for those of you who've done community, it's really difficult to get around the right side of the bed and the right height and things. You'd want to look at the contraindications, so primarily cervical spine, severe OA and things like that. Also being aware that actually it can cause people to throw up on you things. So you'd want to make sure you've got, more space and things.
Oh, you're on mute, Sarah.
Yeah, I just wonder whether it's worth moving on to Nima and Steffi as well. And then I'm happy to say if people want to email me, I could put my email in and things later.
That's fine. I think Nima's on her phone, but we're just trying to get her on her laptop because she's still having some problems. Is it worth us putting Steffi before? Steffi, are you happy just to crack on, and then hopefully we'll get the other problems sorted? Is that okay? I'll hand you over to Steffi.
Of course it is. Hello everybody. I'm just going to share my screen and then I will introduce myself. Right, lovely. So good evening, everybody. Hello, I'm Steffi. I'm an advanced clinical practitioner, physiotherapist on my day job, and an Agile Falls and Bone Health Officer in this setting this evening. I am just going to give a little overview along with Sarah, who's going to come in a little bit later to the presentation, talking about our role as Falls and Bone Health Officers in Agile, a little bit about some of the work that we contribute towards and some of the items that you should be seeing coming out in practice over the coming months. So just to give you an update on that. So as Falls and Bone Health Officers for Agile, we contribute to 3 sort of main steering groups, national steering groups. One being the National Falls Prevention Coordination Group, which is comprised of experts in falls prevention, where good practice is shared. It's around influencing national policy and resources are developed from that meeting. We also contribute towards the National Audit of Inpatient Falls, or NAIF, and this aims to improve inpatient falls prevention and also post-falls care, and this is through audit purposes and quality improvement quality improvement projects that come out of the audits that occur. And the final steering group is the Fracture Liaison Service Database, which is a national audit of secondary fracture prevention in England and Wales. And again, this audit informs practice and leads to the development of resources for fracture prevention. So as well as being part of these 3 large steering groups, we also provide clinical expertise for large-scale research projects across the UK, and I'll update you on one of those in just a moment. And we are lucky enough to be able to contribute towards some nice guideline updates. So one that's in the process of being updated currently is the Falls in Older People, Assessing Risk and Prevention, and both Hannah and Nima are on that nice guidance panel and contributing towards that update, which is great. And lastly, as we are doing this evening, we contribute towards education update for AGILE and CSP members. So some of the projects now that Agile Falls and Bone Health officers have been involved with over that are up and coming and have been over the last few years. One big piece of work that Sarah was really heavily involved with is the launch of the deconditioning resources, which are available. There are links within this PowerPoint as to how to access them. So when the PowerPoint slides go out following this presentation, those links should take you straight forward to being able to access these resources. That these came out of the National Falls Prevention Coordination Task and Finish Group, and were launched in April 2022. And they came, the idea came from the lockdowns, COVID-19, older people not being as active. We all know the risks of deconditioning and the importance of reconditioning and getting stronger post-lockdown, being able to get out and do more and get stronger again. So 5 evidence-based resources have been launched. There's the one in the bottom hand corner here for patients. Have you noticed yourself having less energy since the pandemic started, which gives really helpful information to patients specifically with regards to how they can recondition themselves and become stronger. There are also easy to read versions available for patients as well. There's a resource for health professionals with regards to how we can support our patients to become stronger, what ideas we can give to patients. And there's a resource for commissioners as well with regards to how evidence-based exercise groups and strength training and balance training can be implemented into services to recondition our patients. So like I said, the link there taking you through to the British Geriatric Society website will give you easy access to all of those resources in PDF format. The second project that is out and about for us to use currently that Agile have contributed towards as part of the Falls and Frailty Fracture Audit Programme is the Falls Safe and Careful e-learning modules. These are available through the e-learning for health website, and they are designed for all healthcare professionals, nurses, doctors, allied health professionals working with older adults at risk of falls. They are not designed to replace local falls policies and procedures, but they are aimed to complement those procedures that are in place. So the 2 modules, module 1 is aimed at clinical staff who work in hospital settings, including but not limited to nurses, allied health professionals and healthcare assistants. And the Careful module has been developed for foundation level doctors and includes interactive information about patient and environmental risk factors, patient assessment and post-falls management. And there is a workbook that accompanies the Careful e-learning that is linked to at the bottom there as well. So do have a little look at those e-learning modules and share them with your colleagues. A really useful resource to support our learning. The third project that has very recently been launched is a project that Agile have contributed towards with later life training. And this is referral forms and guidance with regards to referral on for strength and balance exercise programs. So these forms aim to provide information between physiotherapists and exercise professionals who offer FAME and ATAGO based exercise classes. So they're offering those evidence-based classes, and they aim to support with that initial exercise prescription, to support with the sustainability of programs, and ensure that that transition between NHS or healthcare to community, local authority or leisure services providers is a better transition of care, and more patients are followed up with evidence-based strength and balance exercises when they leave our healthcare services. So the aim for this being to improve access to sustained evidence-based strength and balance programs. So again, the link at the bottom there will take you through to the CSP website, which gives you access to the referral forms, which can now be used in practice. And there's an option to have some guidance as well of regards to how the forms should be used and how to fill the forms in. Both us at Agile and Later Life Training are really after any feedback from these forms being used in practice. And if you do have any feedback, strengths or challenges, please send that through to the Agile or Later Life email boxes. That would be really helpful. Thank you. And I mentioned at the start that part of our role with Agile is contributing towards sort of national pieces of research as a sort of clinical experts in our field. And the National FAME Implementation Team, or it's abbreviated to NFIT, is a big sort of big research project going on across the UK currently. And the aim of this project is to increase the spread of FAME, so evidence-based exercise classes for older people across the UK. So the initial part of this work is aiming to double the number of FAME falls prevention sessions in Manchester and Devon. And the goal to double that is to be by the end of 2023. So NFIT are doing this by providing advice and mentorship to services who wish to implement FAME within their areas for the first time. They aim to support and improve fidelity and quality in services which already support FAME provision, so improving services that are already out there, as well as encouraging new services to be set up. They're also supporting commissioners, funders and service providers and PSIs in their delivery of FAME. And initially it's starting in the Greater Manchester and Devon areas, but hopefully seeing success in those areas will aim to the spread more nationally across the UK of these classes. So this is just a little poster showing about the NFIT project and what the NFIT programme can offer: expert advice and mentorship, an online community of practice to share successes and challenges, quality improvement advice to support the development and setting up of services, advice on how you evaluate your service, how cost analysis and outcomes for our patients, and how you get off to the best start with starting up new services. So if you'd like any further information about NFIT, if you would like to contribute towards NFIT, if you're interested in how you can get some support from NFIT, then there's a link there through to the Later Life Training website. And I'm going to hand over to Sarah at this point. Thank you.
Thanks, Steffi. Apologies for the busy slide. I'm trying to do my best to give you a sight of the draft post-fall management decision support tool that I've been involved with Julie Whitney, who is the chair of the National Audit for Inpatient Falls advisory group for probably 2 years now, and we're almost at a time when we can launch and make these resources widely available. But I have permissions from the team to let you have sight of the post-fall decision support tool tonight, just to give you a feel for what's about to land, and probably most pertinent to those of you on the webinar tonight who are working in inpatient settings where you would have clinical ward areas or environments that have got service users who might be at risk of fall whilst in hospital, and also those who would have a role in post-fall management. and falls prevention with those populations. So just a bit of context. Steffi's alluded to the fact that a lot of the work that the advisory group do that's about improvements in practice and supporting best practice at scale at a national level come from the results from the National Audit for Inpatient Falls itself. And so this piece of work is specifically coming on the back of consistently poor reporting against the Falls Quality Standard 4, which is specifically about checking people for injury when they've had a fall. Quality Standard 5, around ensuring that you use effective and safe moving and handling techniques to enable someone to get up off the floor, whether they've got an injury or not, and using the appropriate method in response to the assessment that's taken place. And finally, Quality Standard 6, which is ensuring that individuals who've had a fall are given appropriate medical assessment within a meaningful time frame. And that again is triggered by the nature of the initial assessment and the first response to that individual having had a fall, be it witnessed or unwitnessed, in the environments within which we work. And so what we came together with a task and finish group, which is represented by Julie herself and the National Audit for Inpatient Falls project management team. We've got Julie Windsor from NHS England Improving Patient Safety team, and then representatives from across acute mental health, community and integrated NHS trusts. Also, we've got ambulance providers in there because often they are, you know, those with the most advanced skills in first response, those working in community first response kind of roles, and also trauma and orthopedic medic who's been inputting from St George's as well down in London, just to help us have a really rounded view about what we feel is reasonable in clinical settings for staff to be able to do in response to someone having had a fall. So what we've got is this post-fall decision support tool, which is what it's been decided to be called. And you can't see it in clear detail, so I'll talk you through it really quickly. But the advisory group is happening when, Steffi? End of October?
End of October, yeah.
End of October. So that is when we hope to have everything signed, sealed and delivered and ratified, and then we can go out and make these more widely available. But the long and the short of it is it's about that first response when you encounter someone on the fall. And it's, you know, thinking and merging, if you like, your basic life support and your response to any scene of someone having had a trauma or an injury, and amalgamating that with first aid and obviously your safe moving and handling techniques. So it takes you down through the initial basic life support approach, you know, in terms of whether someone is responsive or not. And I think the thing to say is that this is being developed to be population level, but within that and within the local context, within which has been implemented, you'll need to think about the different populations that you might be working with. So someone being responsive does not necessarily mean, if you ask the questions about whether or not someone can respond to you or not, that someone, for example, with dementia is going to be able to do that. So there are, you know, not contradictory, there are certain populations that we need to think differently about how we actually apply the guidance in the decision support tool. And it takes you down to further steps through to assessing whether or not someone has got breathing absent or breathing present, which triggers your basic life support response, and then thinking about whether someone's got a DNA CPR in situ and your actions then. And then when it takes you right down thinking about whether or not there'd be other reasons for someone being on the floor that might not be fall related at all, if it's been, especially if it's been unwitnessed, thinking about people being in hospital environments in the first instance, and thinking about your news too and your assessments of someone's vital signs and how you might want to do that if you're suspecting something that isn't a unintentional landing on the floor and a typical fall definition. And when we've done that, the kind of key messages that we're putting throughout the decision support tool is to stop and take a breath. So it's trying to stop that reaction of wanting to immediately get someone up off the floor, which we know when there is an injury has the potential to cause further injury and more unintended consequences. And so it's encouraging staff to take the time, step back, take a breath and think about what it is that they need to do and not rush to do something impulsively. And then it takes you down through the look, feel, move context of first response, which is focusing initially on the head, then moving down to the spine, then moving down to the hip, and then moving down to other parts of the body as required. And the look, feel, move, the point to take away from today is that the feel bit is not necessarily, the move bit is not necessarily that you're moving the limb. And that is reflecting the fact that we might have people who are the first responders who don't necessarily have those heightened skills that you would expect an ambulance paramedic to have, or a trauma orthopedic consultant to have, for example. And actually it's about whether the individual themselves can actually move on being asked to, and if that movement is deemed to be normal or elicit a pain response. And so what you're seeing here is the flow chart. All of this is underpinned with a really detailed description of what each step of the flow chart describes, and how you might want to think about so that to enable you to implement that in practice with the rationale that underpins the different stages. And so this doesn't come on its own. It is wrapped around with that detailed guidelines about why the post-fall management decision support tool has been captured in the way that it has. And then what it does is it provides you with an implementation guide that allows sites relative to the organisational type, so be it acute mental health community, as I've alluded to before, and also the context within which you're working in those sites. For example, if it's an area that works with higher populations with higher incidence of falls, more falls incidence data to suggest that there are higher acuity levels in areas, for example, you might take a different approach. And there's been 3 models for post-fall management proposed within the guidelines. One is a specialist peripatetic team that you might expect to find in an acute setting. We have a specific remit for post-fall management who might come and respond like you do with a crash call, for example. Another is a network of post-fall management champions, which you would have at ward or unit level. And that could be individuals, specific professional roles within those individual wards and units, or it could be a cacophony of different MDT representatives. There's no specific prescription there. And finally, there's the third model would be having a wide-ranging core post-fall management skill set and competency across all staff, because it could be that anyone in that clinical area is actually the person who could find someone on the floor unwitnessed or witnessed. And so then that implementation guide allows you to sit down with the right people around the table to think about, if this was our organisation and we wanted to kind of optimise our post-fall management approach, which post-fall management model would we use, and what do we need to make that happen? And that takes you through to a training and competency, a baseline assessment tool, which allows you to run through all of the skills that you need in order to implement this post-fall management decision support tool, work out what gaps you've got, what already is something that you already provide in the organisation, and work together potentially with your moving and handling coordinators, your basic life support team and your physical health team to understand how you can turn this into a bespoke training model for your clinical areas, or is it an organisational-wide training that you do in a half day? And that, for example, is the conversations you have at a local level relative to context and organisational type and the populations within which you're working with. I hope that makes sense. Right, I've lost a bit of my slides, Debbie. Is there a third bullet there that I've missed?
Not that I can.
No, it's just the 2.
Yeah.
No, that's fine.
Oh, sorry, there's the one at the bottom's lying and standing blood pressure.
Oh, lovely, thank you.
Yeah.
And then in complement to this, it's recognising again from the audit that whilst people have got a requirement to kind of assess, one of the nice recommendations is effective measurement of lying and standing blood pressure. There is a lot of feedback through the audit that people do not feel that they've got the right level of skills and competence in doing that. And whilst we've got the RCP training online video and guidance that the RCP have on their website, it's bringing that out again in this post-fall management guidelines in order to support that lying and standing blood pressure being taken at the time someone's had a fall where that's appropriate. And it's sending out some shared examples of good practice competencies that are being used in other organisations. So that's another area of training and development support that will come with the launch of the post-fall management suite of resources, if you like. So I'm really excited. Fingers crossed in October we won't have any curveballs. And at the minute, across the mental health community in acute and integrated kind of settings, we've got pilot sites who've been involved in the development of the resources to date, testing them out in their local organisation, and using that to continuously revise and improve on the resources that we've got. So what you see today might be different in 3-6 months' time based on that learning. And I would imagine the same degree of feedback will be sought from sites when they implement it. And I would envisage, Seppi, that this will probably be then embedded within the NAIF audit tool so that it's really quick and easy to access as people undertake the audit within their organisations relative to falls as they happen. Yeah, thank you. Next slide. So this is just a a cheeky plant for our next event that we're doing in collaboration with Later Life Training, building on the work that we've done to develop the referral forms and the guidance that accompanies the referral forms for, as Steffi's highlighted, for physiotherapists and or those with a role in delivery of falls prevention services and strength and balance programs in the NHS or health-led, and also the same for exercise professionals who deliver those in the community. And the rationale for this event is to help underpin the reasons why the referral forms have been developed and why they've been developed in a longer form and in a shorter form, and wrapping that around the fact that there are differences in the evidence-based exercise programs that we can provide for people who are at risk of falls in the community. So yes, Steffi's highlighted FAME, so your traditional postural stability instructor-led classes and the AGILE leader-led classes, but sending someone to those classes from an NHS-led service or on the back of simply having a multifactorial falls risk assessment is not necessarily effective exercise prescription for those individuals, particularly when an AGILE leader isn't someone who can actually prescribe exercises in their own right. That's not what the AGILE leader training leads to. Again, there's strength and balance exercise classes that we have available to us across all of our local areas, no doubt, but it's kind of that message to you all to kind of understand the skills and the training and the evidence-based underpinning of the classes that are being developed to make sure that you're sending the right person to the right exercise group, because not all exercise groups are the same, specifically when it's around falls prevention management and enabling people to get the fidelity of the evidence base that we need, the right dosage, and also that they're supported to sustain that exercise participation for the length of time that the Cochrane review highlights, and also that they are enabled to do that in a way that is meaningful to them and they adhere. And do that with the support where that's required. So that event I'd highly like to encourage you to sign up to if you haven't done so already. The link is on the slide here, Johanna. So the slides will go out to everybody. If you want to do it now whilst we're in the call, whilst we're on the webinar, I think we can do that, can't we? Suzanne, Sarah, can we copy that link across?
Yeah, I'll do it now.
All right, thank you. That's all from me, unless anybody has any questions for Steffi and myself.
I'm going to stop sharing.
I don't think there were any other questions, but I think it was fascinating just to hear all the hard work you guys have been doing and putting in and all that stuff that goes on in the background. So thank you very much. Shall we pass on? I think Suzanne might be doing two things at once. Suzanne,
yeah, if you can put the link in, Sarah, I'll do Nima's slides for her.
I'll have to find the I'll have to open it up on something else and then find it. So I will do that for you.
Okay, Nima, can you hear us? Can you see us?
Yes, yeah,
okay.
I can see and hear you. Can you all hear me?
Let me just...
Can you hear me okay, Susan?
Yeah,
yes.
Right.
Okay,
let me
good.
just bring up your slides. Bear with me. Right, is that working? No. Bear with me.
I'll just start with my introduction anyway.
There we go. Can you see that?
Yeah. Yes. Yeah. Hi everyone, I'm Nima. I'm one of the last falls and bone health officers, and I also work as a joint and bone health physiotherapist in Kingston Public Health. Really sorry about the trouble earlier, but I am on the phone now, so Susan is doing the slides and we'll get going. So today we're just going to kind of like talk a very snapshot of bone health just in 15 minutes. So it's going to be about who are we targeting, but also some simple promotions in terms of encouraging people to look into their lifestyle for their bone health. So who do we target? Susan, if you, yeah. So ideally, we need to be targeting almost everyone for their bone health, because from the researchers, everything, it's from when a woman is pregnant with the baby, what she's eating, to when the baby grows up to an adult and gets osteoporosis. So you're looking at literally all through your lifespan, but some of them obviously will need a bit more. So you're looking at the age. in women, it's over 50s, in men, it's over 70, more to do with the menopause and the changes in their hormone levels. Gender-wise, obviously females get it more than men, but on the other hand, it is 1 in 2 women and 1 in 5 men who suffer a fracture over 50 just due to poor bone health. So if you think like that, 1 in 5 is still quite a major number, and this is for people over 50. So we haven't gone into the 80s things where the number goes much higher up. Also, we need to think about the lifestyle of people before their 30s. Again, there will be some of these that we discuss later that you might understand, but you're looking at people who either didn't have a full balanced diet growing up, or are not being much active when they're young, or having eating disorders, health conditions that might have an impact as well. So the lifestyle before their 30s comes in very handy in understanding the people at risk. People who don't take enough calcium for whatever reasons, either they are intolerant to dairy products, or it might be they have health conditions that are affecting them in absorbing calciums like celiac disease. So you're looking at both the absorption as well as people actually having calcium in through. Vitamin D, again, it goes back to the same thing, whether in terms of, are they having enough vitamin D? Are they having too much alcohol that's interfering with their vitamin D deficiency? So you're targeting the people who might have kidney problems, liver problems that's changing their vitamin D deficiency, it's not acting on them, or people who are kind of like not actually out in the sun as much, not getting enough sunlight, or have to have sun lotions on, suntans on before they go out because of their skin conditions. People who are inactive or bedbound, again, we tend to lose our bones from each week that we are actually in the hospitals, and that goes through in terms of us putting weight through our bones. You're looking at astronauts, people in the space losing their bone health, and therefore they are doing weight-bearing exercises in the space now. So you're looking at thinking people who might have had stroke and therefore unable to put the weight on that side, their bones on the weaker side is going to be more, they're going to lose more bone loss happens on that side compared to the other side. So any health conditions, any reasons why the person is not actually being as active, being able to put the weight through, again, this goes both for the legs and the hands. So it's understanding that the whole body takes the weight as well. Diet restrictions. So we talked about calcium and vitamin D, but in general, we need a full balanced diet to help our bones and them. So you're looking at, for example, celiac. People who suffer from celiac conditions are at risk of osteoporosis. So you might be thinking, again, that's gluten there, but it does kind of like interfere. So looking at diet, if someone is avoiding a particular group of food completely, then they are going to be at more risk of osteoporosis or losing their bones. Yeah. Health conditions. So we are talking about parathyroid, high parathyroid, or high thyroid levels will interfere with your metabolism, but also looking at rheumatoid arthritis. Again, that has a huge link with osteoporosis. So people who might have eating disorders, as I mentioned before, especially if it happened to be a female who stopped having periods for any number of months, again, will increase the risk of their bones actually being lost there. Other health conditions like people who might have COPD or Parkinson's, therefore not actually having enough nutrition food or not eating well, that plays a role. Health conditions that affect the absorptions. So you're looking at Crohn's disease, ulcers, again, that interferes. You're also looking at the kidney liver conditions that might interfere with the calcium and metabolism of the calcium and vitamin D transformations. Women having menopause is again high, and especially if they had their menopause quite early. So anyone who had the menopause before they are 45 is normally considered as an early menopause. So if someone said they had their hysterectomy in their 30s, you are looking at them as well as a risk factor. Okay, Susan, if you can move the slide to the next one, please. Thank you. So we touched on menopause. Women tend to lose 50% of the bone loss happens actually in the first 10 years of menopause. So you're kind of looking at huge amount lost there. So that goes into the sex hormone levels, whether it's a man or a woman. So prostate cancers or people who go through surgeries that actually change the hormone levels. Again, when there's a sex change, that kind of, again, if they're not actually having the right hormones, that does affect their bones as well. Medications, why people who are taking steroids, if someone is taking oral steroids, especially if they take it more than 2.5 milligrams, for example, prednisolone, for more than 3 months, someone should be looking at their bone health to see if there are any other risk factors. Do they need extra medications to support them? The other thing that interferes is some of the anti-epileptic drugs, especially the old ones. The longer someone is on them, or the more different ones that they have tried for long periods, they are again at more risk of osteoporosis there. The other drugs you talk about is the cancer treatments, especially the aromatase inhibitors. Again, a lot of women, when they have breast cancer, so they are treated with these. But again, looking at their medical history, their risk of bone levels, and kind of assessing them and giving them the right idea. It might just be diet, but it might also mean that they might need medication for their bones at the same time. Family history is huge, especially if a mother or father had a hip fracture. That definitely increases the risk of the offsprings getting osteoporosis. You're also looking at family history in terms of rheumatoid arthritis, celiac conditions that might run in families, and just genetics, bone build, how strong or how weak your bones are. That's completely through the family there. The other thing that doesn't actually help in terms of family history is the period. How the period actually runs might be the same from mother to daughter. So if a mother had an early menopause, again, that might be something that the daughter might have as well. I mentioned the bone structure and body weight. Again, that's absolutely genetics in terms of like saying how strong someone's bone is. And if they are quite petite, again, they are going to be a little bit more at risk as well. People who are smoking tends to have more risk of osteoporosis. It interferes with the calcium and vitamin D, but also it changes the hormone levels. That actually doesn't help. We are also looking at, the smokers have a longer healing time, which again increases the risk of osteoporosis. So if they have a fracture, it's going to take them much longer to heal. Excel alcohol, again, I'll talk a little bit more onto it. I just realized I have slides on those. Sorry, Susan, I was trying to kind of click mine and realized it wasn't moving. So what helps? So we kind of spotted all the people who are at risk, which is quite a huge population. How do we help? Is diet, exercise, lifestyle changes are the major ones. Of course, there's medication as well. So it is understanding them. Susan, if you can move it to the next one, please. So as I mentioned first, it's the healthy, full balanced diet, not just your calcium and vitamin D. So it is understanding that the body fat actually produces some estrogen, especially in postmenopausal women. So it is telling people they can't omit a complete group of food for whatever reason. So if they are omitting, then they need to make sure they are getting the right amount of those vitamins and minerals that they're lacking through that. I'm going to talk about calcium and vitamin D today, but there are other things that are more important as well. Some of the vitamins and minerals like vitamin K, C, but also you're looking at minerals like boron, magnesium, etc. But the conclusion is, if you have a full balanced diet, especially fruits and vegetables with different colors, the amount of things that you need in terms of the other vitamins and minerals will be achieved just by your balanced diet. So we don't have to have supplements to actually make that work. Passing on to the next one, please. Thank you. So calcium and vitamin D. I'm just going to bring it up in mine as well because it's too small for me to see there. So calcium, as an adult, we should be taking about 700 milligrams for an adult. And for people at risk, it might go up to 1,000 milligrams. Now, the calcium, we always advise people to take it through their diet because you can overdose if you take it as supplements. So if you are when you're recommending people, it's always advisable asking them to take it as diet. But if they definitely need it, then they will be prescribed, or they can talk to a nutritionist or GP to kind of like decide the right level of calcium for them. So again, all the calcium products, whether they are zero fat or full fat, will still have the same amount or slightly more calcium in the zero fat versions. So again, telling people who might have cholesterol problems, heart problems, they don't want to take the full fat versions, they can still have the zero fat versions. For people who are vegan, all the plant-based yogurts and milk and everything, a lot of companies have started adding calcium to them. So as long as the company they're buying things from actually has added or fortified calcium in them, then therefore these people will get the same amount of calcium as someone who's drinking a cow or goat milk will get. The other thing you can tell your clients is to look at the Royal Osteoporosis Society website. They do have leaflets on which food has what calcium levels, but also they have something called a calcium calculator that you can use to kind of find out how much calcium you're taking over a week. And then that gives people an idea of saying, are they taking enough, or do they have to increase their intake? In terms of calcium, something came up. I kind of forgot which one I was talking. It will come back in there. But it is kind of like keeping an eye. It's not just the dairy products. Even the plant-based dairy has the same amount. But also you're looking at other things like tofu, sesame seeds, baked beans. There's lots of other foods that do have calcium. So it is kind of making sure that you're having the right amounts through. Vitamin D, the recommendation is all adults should take 10 micrograms. And that's at least during the autumn and winter. It is kind of like, again, for people who are at risk, it can go much higher than that. People normally, for someone with osteoporosis, they might be given 20 or 25 micrograms per day. Now, for someone who's very deficient, they will go on a very high dose for a short term and then go back. So vitamin D is fat soluble. So ideally you want to eat it or have it when you're having food that has fat in them. But if that's not possible, something is better than nothing. So it is come through. Again, there is D3 and D2 versions. So D3 is animal-based and D2 is plant-based. So again, you might have vegans saying they can't take them. So there are D2 bases. In terms of its absorption, it's not as highly absorbed as the D3 version, but if people can't take D3, then there is other options. And again, there is margarines, breakfast cereals, yogurts, etc., that have been fortified with vitamin D, which people can use as well. In terms of calcium, that's something I was going to say, is some of these things are fortified with calcium as well that you can kind of use through. The next slide, please. Yeah. So exercise-wise, the general recommendation that we all should know is 150 minutes of moderate intensity of physical activity. Again, are your clients doing them? And the other part is, are they doing the muscle strength? Because even though they are muscle strength, they indirectly support your bones getting stronger as well. So it is making sure if they are doing them correctly. And I know the balance is left for the older adults over 65, but physio students, when they come for my classes, they struggle with their balance. So, it's not in terms of age, it's about how much they can do, but are they doing at least twice a week of balance exercises? And the other part to really remember is to not to sit for too long. So it's about encouraging weight-bearing activities through. Next one, please. So the Royal Osteoporosis Society, they actually recommends 3S. So it's strong, steady, and straight. So within the strong comes your weight-bearing activities. You're thinking about your 50 impacts on most days, and muscle strength activities at least 2 to 3 days per week. And again, it can be exercise, but it can be muscle strength activities is up to which one of the person can do them. And the impact changes between people to people. It could be a hop, it could be jumps, it could be stepping, it could be walking, it could be for a stroke person, it could just be leaning to that side. So the understanding the level of impacts that someone can do, if someone just have had a vertebral fracture, their impact level will be a lot less to start with, and then you gradually build it up. Next slide, please. Susan. The next S is for the steady, to improve your balance. Again, it could be any Tai Chi, dance, or balance classes, balance exercises 2 to 3 times per week. And the next one, please. And then, so we're kind of thinking about our posture straight. So again, kind of like the posture is like all the time, not just when you do the exercises, but also trying to kind of get your back muscles stronger around the same time to help with the posture through. Again, for someone who's just had a vertebral fracture, it will be every day back exercises, but the others, it kind of goes back to the 2 to 3 days per week. Next slide, please. So medication-wise, again, nice guidelines on different drugs in different situations was a huge amount. But I think mainly as a physiotherapy, you're looking at the medication adherence. Are people taking the medication they're supposed to be taking? A lot of them, I spend most of my time convincing patients on why they should be taking their tablets, because there's a lot on side effects, which kind of changes people's mind, or it is, again, pointing them to say, actually, calcium, I can't chew, I'm struggling, therefore I'm not taking it. So it's advising there are more than one way of calcium, and there are some that's not as easily Some people find it hard with their tummy, while if they go into like a different version, they are okay. So it's understanding there's more than one type. They can go back to the doctors who are prescribed to have the different changes in that. And in terms of like bisphosphonates, which is normally hyaluronic acid and things that are normally given, the side effects, people are quite aware of side effects and they don't want to take them in case they have those side effects. Again, pointing them to kind of talk more to the whoever has recommended the tablets. Also, Royal Osteoporosis Society gives them an idea in terms of talking about things that actually can help. Also checking out if people are taking calcium and vitamin D, especially if they are prescribed, are they taking the prescribed ones? Sometimes they say, oh, I've got the injections, therefore I don't have to take the calcium and vitamin D. It is understanding, even though they're taking the osteoporotic drugs, if they have enough calcium and vitamin D, that's when they will be working efficiently. So making sure that they are having the right amount of calcium and vitamin D, either through their diet or through prescriptions. Drugs do wear off and stop, and some people might go on like drug holidays, which is about like a couple of years. But again, it's kind of keeping an eye on them. And if they do have a fracture at that time, is highlighting it that they need to kind of might have to go back on the drugs, so someone had to review their situations. Next slide. Yeah, so I think I kind of touched a little bit on this. It's just got a website on quit smoking at the bottom. So if you can go on to the next slide. So alcohol, again, it interferes with the calcium and vitamin D, but also the hormone levels as well. But when we are drunk, we are a little bit more likely to fall, and therefore the fractures comes in as well. 12 to 40 units was kind of like the higher amount you can have in a week. No binge drinking in one day, and making sure there is a 2 or 3 days of rest as well. But older adults are supposed to take much less than that, and they will know their limit in terms of how much they are kind of going through. But something quite easily done is understanding the units. We don't always kind of realize how much a unit is. So a simple 125 ml of a moderate wine is about 1.5 units. So if you think like that, someone saying, I have like a cup of, sorry, not a cup, I don't drink, you could see, 1 glass of wine every night, it could easily add up to the amount. So it's understanding those. Next slide, please. Yeah. So trips and falls, anyone can fall at any age, but obviously if someone is at risk of osteoporosis, they're more likely to fracture. Again, here comes the person assessing the person in terms of their health risk levels, etc., but also assessing their environment so they don't actually impact. So next slide there. So this is just a conclusion to kind of think about when you're advising or telling suggestions to people, think about 50 impacts more days, think about the muscle strength and balance at least twice a week, and think about vitamin D supplement, which most of us should be taking, and think about calcium in the diet, and especially if they have been prescribed medication, making sure they are taking them, but also making sure they are having a healthy, balanced diet, and also maintaining a healthy weight. Next slide, please. So Royal Osteoporosis Society has got lots of information as well as exercise videos, and so that the other part to look out for is British Dietetics Association, which are like food facts. So for someone who might avoid a certain food group, they can go into that to see what other options they have got there. And obviously there's a nice guideline. And if you need more information, you can contact us in AGILE Falls Officer as well. And I conclude with that. You can ask me any questions. I can't see any chats at the moment, so I'm leaving.
I think there's just one question, Nima. So should vitamin D be taken with K2 or no evidence? Question mark.
Yes, yeah, K2, I think there was kind of a lot of evidence, but a lot of them have been scrubbed off now. So we are going from scratch again now in terms of K2. So at the moment, there's nothing saying that you need to take extra K2. As long as you are taking a fully balanced diet, your K2 comes from the fruit products. Obviously, if someone is taking K2, they do have to think about if they're on warfarin and things like that, because it does have the clotting factor as well. Is there another question that just flashed up?
Yeah, sorry. Do you complete FRAX scores for your patient groups with the new osteoporotic, I can't say it, guidelines?
Yes,
definitely.
Definitely. I actually had a slide on things, but I thought 15 minutes, I can't really kind of go on everything. Definitely. And FRAX score is so quick and easy to do. And all the risk factors that I mentioned is very easily come forward into the FRAC score. And you don't need a DEXA scan, and the DEXA scan is not recommended for everyone anymore. So from that point, FRAC score easily gives, and what we do it literally for every person. And because I work in public health, people self-refer a lot. And then we send it to the GPs. If they have a medium or high score, we send it to the GPs, who will then, and we have a local policy on who to act on as well. But now the FRAC graph has got a treatable margin, which makes it even more clearer that who should be treated and what to look out for. But yeah, definitely FRAC score is quite good, and that kind of easily gets someone prescribing medication to the client. So at least sending them for a DEXA scan. It gives a conversation with the GPs to talk to the clients about their bone health, because it's always forgotten. So it's kind of like nice for them to see a graph or something that says, oh, Amber, I need to do something, and go through.
Okay, thank you. There's a couple more questions and then we'll have to move on. But so okay. Alex has asked, do antipsychotic meds impact on bone health?
Yes, yeah, not all of them. Again, this is where some of the antidepressants as well. So it is looking at exact the medication that they are taking, but it seems to be with the antipsychotics again. I can't really remember on top of my head. It's the longer term that they are using it. That seems to be more of impact, but there's definitely some of the drugs, I can't remember the names, but definitely some antidepressants that are included as well.
Okay, and just the final one now, and then we can, Nima, you can, hopefully people can get in touch
I can talk afterwards.
Yeah, yes, yeah, okay. Regarding drug holidays, so Richard's asked, regarding drug holidays, what would be the potential side effects if patients don't have them?
I think with the evidence, bisphosphonates, especially, it's said like most of the fractures and things, the thigh fractures and things seems to be happening when they're on it for 8 years, 10 years or longer. I've met clients who had them for 20 years without anyone ever even looking at them. So it is kind of like, so the recommendation is you can go up to 5 years, but at least someone has to review. Again, there are people who might still have to continue, especially if they had fractures and they are on steroids. So they will still continue without having a drug holiday at all. But it is again weighing up the major goodness as such. So you kind of like manage what else is on the option. Sometimes when people are on drug holidays, they might fracture, and that's when you need to trigger even more into kind of getting them back onto the system, and they might have to start more than wait for 2 years.
Okay, thank you. Thank you. So I'm just conscious of time. So Pauline is going to give us a quick overview about fall fighters, I think. Pauline, are you with us? There you are. I shall share my screen. Hopefully this will work. Bear with me.
Lovely, thank you. I can see that.
There we go.
Okay. Well, good evening to you all. Thank you for the invitation to join you here this evening. My name is Pauline Herbison and I work for ROSPA, the Royal Society for the Prevention of Accidents. I'm their public health officer. So ROSPA is acutely aware that falls are the single biggest cause of accidental injuries in the home, and sadly, the largest cause of accidental death among over 65s in the UK. So our Fall Fighter campaign has been devised with that in mind. Could I have the next slide, please? Thank you. Fall Fighters was developed as part of ROSPA's partnership with the RSA Insurance Group to raise awareness of how to prevent falls in the home. It followed other successful activities, including a series of online roadshows and the development of a web hub giving fall prevention advice. So the Fall Fighter campaign focuses on making our online awareness sessions available to all. They are free to attend and they equip people with knowledge so that they can share fall prevention messages. The subject matter covers the causes of falls, who's most at risk, and how to prevent falls. The importance of strength and balance exercises are emphasised, and the sessions also cover simple checks around the home. Next slide, please. There are 2 routes to becoming a fall fighter. The first route is attendance at a short individual e-learning course. Any person is welcome to attend that. And the second route is for volunteers from organisations like workplaces, charities and community groups. They can download a short self-led workshop to run with others, or alternatively, they can download e-learning files to upload to their own e-learning system. Next slide, please. Thank you. After completing the session, delegates receive a certificate and can download further resources to help them share messages about falls prevention with families and friends. That can include, for instance, finding out whether they need an eye test or doing a home safety check and looking at what cheap and straightforward changes around the home could improve safety. Next slide, please. Thank you. ROSPA is working closely with local partners who are introducing fall fighters across their workforce. And you can see here some of the examples of organizations that we have been working with. Berkeley Group is one example. The Fall Fighter scheme fits well with our strategic focus, they say. Adding it to our own LMS makes the rollout simple. Severn Trent have said that they're proud to adopt this free scheme and encourage their 7,500 employees to become ROSPA Fall Fighters. And we have the East Sussex Fire and Rescue Service on board as well, saying becoming a fall fighter is an excellent way for you and your employees to increase your knowledge on how to prevent falls in the home. Now, these are only examples. We have a lot of organizations on board with this. Next slide, please. ROSPA also has a range of resources for the public and professionals on our Falls Prevention Web Hub. The web address is displayed at the bottom of this slide here. So visitors to the hub can select which group they fall into. You can see the 3 groups up at the top of the slide. The later life category, family member of someone who is in later life, or whether they work with people in later life, and resources are then tailored for each group. You can see examples of the resources and the information that is hosted on this hub. We have examples of strength and balance exercises. We have demonstrations, video demonstrations. We have videos on how to make your home safer, and also checklists as well, which are available. Next slide, please. Thank you for listening. I know this was a whistle-stop tour, but if you would like any further information, please contact myself, P. Herbison at rospa.com, or my colleague, Ashley Martin. You have both our email addresses there. You may also be interested to know more about our Falls charity appeal and our call for safer stairs. We would be very happy to answer any queries you may have. If there's time now, I'm happy to answer any questions you may have as well. Thank you.
Thanks, Pauline. That was great. Any questions for Pauline? You may have got away with it, Pauline. Everyone's flagging now. Oh, here we go. Victoria's asked, do you have training materials suitable for nursing homes?
We do. Now, we do run courses as well. If you want to get in contact with me, we should be able to help you.
Okay, thank you. Any other questions, comments? Okay. And any other final questions or comments for any of our speakers tonight? Oh, here we go. Sorry, another one for you, I think, Pauline. Philip has asked, do you work with building designers like McCarthy Stone?
Now, McCarthy Stone isn't familiar to me, but yes, we do work with various other organisations that are involved in the building trade. In terms of safer stairs is an interesting one. We've done a lot of work with the building industry in that, because we've actually been successful in getting the government to consult now and make a particular British standard mandatory. It has been discretionary up until now, and that means then that treads would be set for all new buildings. They would be the same dimensions. Slip resistance would be made mandatory as well, and 2 handrails instead of 1 would be made mandatory. So we have done quite a bit of work with the building trade on those kind of campaigns.
That's great. Thank you. Somebody's just asked, will the slides be shared? Yes, I think that's okay if everybody, I'm speaking on behalf of the speakers, but yeah, I think that's fine. And like I said, we will have a copy of the recording and we'll put that on our YouTube channel. So another question, perhaps for everybody, are there any databases to locate where FAME and Otago classes are happening in local areas? Can anyone answer that?
Bex replied to me, and I bounced it back to you to answer. The individual asked us via email, I think. Let me see if I can pull my email up. I think it's a recurrent issue for later training, isn't it? That they haven't got the ability to keep that database maintained. But I think MFIT is the solution. Is that right? Am I remembering that correctly? Maybe that they think that the work from MFIT will help them. Let me just pull up the email.
Yeah, no, I think you're right. So right? There isn't currently a database at the moment, that there's something that they're aware that there is a gap. Yeah. But hopefully with the MFIT stuff, we'll filter some of that.
Drive that need for people to yeah.
It is a question we get asked quite often from people.
So we would suggest you kind of make contact with your public health or your OHID lead for Aging Well, or what, because every system, whether it be ICS or partnership, is going to have a different title for the person in the role that has that responsibility and oversight of the kind of falls, strength and balance offers in the community that are not NHS kind of funded and led. Often it might be somebody who sits in the OHID team or the local authority. So if you have a falls lead at place level, go to them, try and find out who the right person might be within under Aging Well or in the OHID team, and start to ask those questions at that level, because that will trigger, I suppose, a local understanding of where you might be able to get that information, and if it isn't available, how you might start to kind of build that repository and that understanding up locally. So that's what we would recommend from an agile perspective, not least to start building those relationships across the entirety of the falls pathways and build those relationships with multi-sector partners.
Great, thanks Sarah, thanks Hannah. Okay, I think that is probably us done. Just to say that tomorrow Sarah Lambert will be sending out a feedback form, which if you complete, you will then get a certificate to say that you've attended. We all love a certificate, so please do give us any feedback about tonight's event and anything that you think we should do moving forward. Obviously the vestibular stuff Hannah got raised straight away, so that's something for us to think about. But yeah, so thank you all very much for attending. Thanks to Steffi, Hannah, Nima and Pauline and Sarah for all your fantastic talks tonight. Really appreciate it. We hope to see, well, we've got lots of other events coming up, so we hope to see you all again soon. Yeah.
You can stop recording now, Suzanne.